necrotizing abscess on his face. He had enucleation of his eyeball, and the pus was removed. During that time, Howard Florey, who was in Oxford University working on penicillin, experimenting it on mice, offered to try it on Alexander. He was given penicillin, and within a day, the Albert Alexander started to recover. But Florey's team didn't have enough of the drug to see the patient through full recovery. Their efforts to recycle the penicillin by extracting it from his urine failed, and unfortunately had to relapse, and he died. 1 year later, penicillin was given for the second time to a 4-year-old child with strep infection. As you can see here, she had a very bad infection. This time, they did not require a large quantity because this was a small child, and they managed to treat and cure this baby. And since then, penicillin has been used to treat many infections, including syphilis, traumatic wound, pneumonias, and many other antibiotics have come along. However, today, we are seeing more and more reports all over the world about the failure of this miracle drug. It has been to treat commonly encountered infections such as urinary tract infections, skin and soft tissue infection, surgical site infection, and even TB. It is estimated that one person gets infected with a multi-drug resistant organism every 15 seconds in the US, and 11 seconds in the US, and one dies every 15 minutes. It's estimated by WHO, which is a gross underestimation, that 700 deaths due to multi-drug resistant occurs, and out of it is 230 multi-drug resistant tuberculosis. Therefore, in May 2015, at the 68th World Health Assembly, MDRO was recognized as an important public health problem, and a global action plan was developed. Yearly hand hygiene and World Antibiotic Awareness aims to increase awareness of the further emergence and spread of multi-drug resistant organisms. To achieve this objective, and in keeping with the theme United to Preserve Antibiotics and Clean Care Saves Life, we have experts from various expertise to discuss this topic. Our first panelist is Associate Professor Dr. Sharifah Farida, Consultant Infectious Disease Physician. We have Associate Professor Dr. Kong Tak Lun. He's Consultant General and Colorectal Surgeon, and he's the head of the Colorectal Unit in the Department of Surgery. Associate Professor Dr. Azana Ahmad Kamar, who's a Consultant Neonatologist and the head of the Neonatal Unit, the Department of Pediatrics, and we have Dr. Lim Hui Min, a clinical specialist from the Department of Primary Care today, to share their experiences and challenges that they face with multi-drug resistant organisms. Thank you all for coming. So we'll start off. We depend a lot on life-saving drugs such as asthma, heart disease, cancers, and they all seem to work after years of using it. Antibiotics, however, worked for a while and then stopped working. Dr. Sharifah, what is it about antibiotics and bacteria that makes it a different challenge compared to all the other drugs that we see?
Hi, good morning, everyone. Thanks, Ashila, for inviting me for this forum. Gives me great pleasure to be here. So the question is why, what is it about bacteria and antibiotics? Why do they develop resistance? So unlike other diseases or illnesses, when you are treating an infection, you are actually dealing with the living organism, which is the bacteria itself. So living organisms will always try to survive. They adapt, they change themselves so that they can overcome whatever obstacle that is put in front of them. The obstacle here is your antibiotics. So after a while, the bacteria will always find a way to survive the attack from antibiotics, and this leads to resistance. As mentioned by Sashila earlier, the first antibiotic, penicillin, was discovered in 1928 and released for use in 1941. But within a year of being released, penicillin-resistant Staph aureus emerged. And since then, with every release of antibiotics, resistance bacteria will emerge soon after. So the process of developing resistance happens every time you are exposed to antibiotics. So in graph here, in this picture here that you can see, patients basically, those who are exposed to antibiotics. So if you look at the picture going down, antibiotics are given to the patients. And as I said, every time you are exposed to antibiotics, you may develop some resistance to antibiotics. So this develops in the gut. Patients attend clinics or hospital with carrying this drug-resistant bacteria in them. And because if there's poor hygiene or poor infection control measures, the drug-resistant bacteria can spread from one patient to another within the hospital. Drug-resistant bacteria can also spread to the general public when they go back to their communities. Another way that resistance occur and spread is because of the use of antibiotics in the agriculture industry, in animals and also in crops. So the animals develop drug-resistant bacteria in the gut, and this is the very thing that we actually consume. So we're actually consuming the bacteria together with the animal that we are eating. And this is another way of how drug-resistant bacteria spreads to the general public. So the process of resistance, it just happens. It's a natural evolution process. But it is accelerated the more time that we are exposed to antibiotics, the more times that the antibiotics are given not for the right reason or given not at the right dose. So it's always important to try and minimize the emergence of resistance every time we use antibiotics. Yeah. Sashila, does that answer?
Yeah. Thank you, Dr. Sharifah. I mean, that is really, I think you've said it very, very nicely. Like, what are all the factors that can select out resistance and then propagate the spread of infections? Is there any particular organisms that that we consider a threat? Are we supposed to be scared of one bug, or is it many bugs? What are your thoughts on that?
So, there's lots and lots of bacteria out there, but the ones that we are really worried about is the ones that have this multi-resistant strain. So there are a few categories of bacteria that clinicians especially are worried about. So, there are different levels of it: medium, high, and critical criteria. So I'm sure everybody has heard things like VRE or vancomycin resistant enterococcus. MRSA is very, very, very famous, if you like. Methicillin resistant Staph aureus. The ESBL, extended spectrum beta-lactam, is producing Enterobacteriaceae. Acinetobacter baumannii is very commonly seen in our ICU patients who are intubated and ventilated. So there are many, and more are coming up in terms of bacteria with resistant strains in them, and it's becoming more and more worrying.
Thank you, Sharifah. So, Dr. Hui Min, apart from inappropriate use of antibiotics in the animal sector and by healthcare workers, how are antibiotic misused by the public in the community, in your practice or your experience? Do you see patients, taking antibiotics inappropriately, and how is it usually inappropriate in your experience?
Yeah, hi, good morning, everyone, and thanks, Prof. Shashila. So in terms of antibiotic misuse in the community, and yes, we do see a lot. Sometimes patients kind of self-treating themselves with the antibiotic, with their leftover antibiotics or antibiotics from their family and friends. I think right now it's not quite easy to purchase over-the-counter antibiotics, as most of the retail pharmacies refuse to sell. So they kind of come to our clinic and demand for antibiotics. So this kind of patient pressure is also one of the factors that patient kind of expecting to go back with antibiotic when they feel sick, and they usually will come to the primary care clinic. So besides those like direct demand of antibiotic, and there's sometimes this kind of misunderstanding to encounter in our clinic consultation, where patients sometimes will perceive that patient is requesting or expecting antibiotics. For example, if the patients complain that over-counter medication is not working, or they kind of questions the doctor whether an antibiotic is needed, and physicians might perceive that the patient is kind of expecting the antibiotic, and they were more likely to inappropriately prescribe the antibiotic. So, and hence I think it's important to kind of explain patients' concern and patient expectation when they come for the clinic consultation, to have more patient-centered kind of management, and to see what is exactly the expectation. They sometimes might just need an assurance of their mild illness.
Yeah, I mean, and what do you think is their level of awareness? Patients, when you do advise them, like, you don't need to take antibiotics, what do you think is their level of awareness, and also the level of awareness of doctors, to succumb to this pressure?
Yeah, so I think generally the awareness of antibiotic use in the public and the general population is quite low, and several studies have done in our local populations as well to look at their knowledge of antibiotic. So there are a lot of misconceptions on this use of antibiotics and the roles of antibiotics. So public or patients believe that antibiotic is effective in treating viral infection, common cough and cold, and majority of them are unsure what is the meaning of antibiotic resistance and the consequences of it. How about healthcare workers? But I think with the ongoing antibiotic stewardship program over years, there are awareness of this antibiotic resistance in the healthcare providers. But as we can see from the data, there are still about 20 to 30% of antibiotic inappropriate use or prescription among the doctors in primary care clinic, and especially over the private sector as well. So, and the most commonly prescribed antibiotic is for acute viral respiratory tract infection. So I think there's a gap that we kind of have to fill in, whether how to fill in the gap of translating their knowledge into the clinical practice, as I think this will kind of help to reduce the antibiotic prescribing for inappropriate condition. Yes, Professor Sheila?
Yeah, thank you, Yumin. So, Sherry, I have a question for you. So it's the awareness is poor, to a certain extent among patients, also our healthcare worker. We are still learning in many aspects. Do they know what is actually the impact of these multi-drug resistant organisms? Why do we need to care so much about them? Sherry, you need to unmute.
Yeah, okay, sorry. So MDRO is not just about, not having the antibiotics to treat. Obviously, there are consequences to that. So it can potentially affect people at any stage of life, as well as many industries, not just healthcare, but veterinary, agriculture industries, and so on. So it is an urgent public health problem. When we cannot treat infection anymore with using first-line antibiotics, we need to use more expensive medication. A longer duration of illness and treatment, often in hospitals, increases healthcare costs as well as economic burden on families and societies. So, failing to respond to a standard treatment using first-line therapy just prolongs the illness, increases the length of stay in the hospital. This increases the cost, not just to the patient, but also to the general healthcare system. And finally, obviously, if we can't treat infection, this will also increase the risk of death and also morbidity, not just mortality, but morbidity as well. So it has a huge impact.
Thanks, Sherry. Yeah, so it is a big problem. On top of that, WHO has said 1 in 10 patients get an infection while receiving care in the healthcare setting. And healthcare setting, meaning this is also known as healthcare associated infections. This could be infections due to a line that we put in, a line-related infection, or ventilator associated pneumonia, or even infections that we get after a surgical procedure. This is quite a high number, 1 in 10 patients. So, Prof. Kong, can you tell us a bit about the burden of surgical site infection? What are the global rates like, and how are we doing compared to the global scenario?
Yeah, sure. Thanks very much, Sheila, for inviting me to speak today. And I think it's a great initiative to get all the stakeholders on board here, people who use antibiotics routinely. Every time a patient is subjected to an incision, surgical incision, unfortunately, there will be a risk to surgical site infection. However, there are many things that we can do as a healthcare professional and also patients to try to affect that possibility and risk of developing an SSI. So if we were to look across the board in terms of incidents, it does depend on where the data is obtained, depending on what is the cohort of patients that are studied, and also how it's reported. So if we look across the board, there are various numbers that have been suggested. So the US seem to report an SSI overall rate of 1%, but that is across the board of all different surgical specialties, whether it may be clean surgery, clean contaminated surgery. As a colorectal surgeon, obviously our SSI rates are higher than 1% as to be expected. And the data from the UK suggests that it can be up to about 10%. So in UMMC, we have taken the appropriate measures, and we've actually managed to knock it down to roughly about 5% thereabouts on our annual audit data. Now, thanks very much, Sheila, for sharing the data from KKM. And from their audit data from the infection control units there, they seem to report an SSI rate of about 1% as well overall for all for all admissions for surgery. So out of 100 surgical procedures in a year, about one patient out of that will develop SSI. So I have to say that we are doing pretty well actually across the board, if to compare ourselves to a developed Western nation. But if to then isolate and we comb down to HCAIs as a whole, so healthcare associated infections, unfortunately, SSI still accounts for a large proportion, accounts for about 25%. So clearly, this goes to show that there's a lot that needs to be done to address this issue. Thanks.
Yeah, you're right, because other than SSI, there's also ventilator-associated pneumonia that we see in line-related infection, which is quite high. Prof. Kong, what do you think is the awareness of surgical site infections or multi-drug resistance or even other healthcare-associated infections among the surgical colleagues and also patients?
So thanks very much for asking this question. And I actually have done a survey. So could I share my screen, please? Can all of you see my screen? So I did a survey of the surgical department. So I have to thank all my colleagues for their contribution. So how I derived this survey is basically to use the this survey that was done just a few years ago by the European CDC, Control of Disease and Infections. And essentially it looks at knowledge, awareness, behaviors, and attitudes. So what I did was that I transcribed some of these questions from the survey, and I've actually generated a survey for our own staff. And this is the demographic. So I had 68 responses. So thanks very much everyone for participating. Most of the participants were from the Department of Surgery. Yet again, I have to thank my colleagues for their contribution. And that one anesthetist who contributed, thank you very much as well. As you can see from the breakdown, most of the people that participated in this study or survey actually prescribe antibiotics quite routinely. Most of them prescribe daily and some of them weekly and very few of them monthly or less frequently than that. So I think across the board, it's good to see that we are aware. Overall, a large proportion of us are aware of what antibiotic resistance is. And most of us also acknowledge the fact that we have a key role to play in controlling antibiotic resistance. So that is very reassuring. So when it comes down to behavior on antibiotic use, yet again, majority of us would actually consider antibiotic resistance when we treat patients. But this is where it starts to get a little bit interesting. So maybe this also broaches a bit of what Raymond was describing earlier on, where if we actually needed to give information to the patient in order to drive that knowledge to them to say that maybe antibiotics is not required and why we should be prudent about antibiotic use. Yet again, yes, majority of us feel that we have the information that we require to give to the patients, but note that the spectrum starts to shift more towards the, I'm actually not too sure now. And this is where it starts getting interesting. So obviously, in order for you to provide the right information to the patient, to counsel them, you obviously yourself need to have knowledge on antibiotic use. And when I ask them about the sufficient knowledge that they think they have in the use of antibiotics appropriate for their current practice, yet again, yes, it's reassuring that 3/4 feel that they are relatively comfortable, but start to see the shift again towards, maybe I'm not too sure after all. And maybe that is explainable because, the world of antibiotics is shifting and it's changing quite rapidly. And as busy surgeons, we may not have the time to actually acquaint ourselves to antibiotic therapies and what's the best for our clinical use. And so maybe that would explain for why people may feel that they're just not that well versed with use of antibiotics in their current practice. And this is where I think what we can do, Sajila, because if we don't have the right information, then surely we should be able to make the information more accessible. So interestingly, from this question, some people or most people feel that they have access to the material that they need to guide them on prudent antibiotic use. But yet again, look and see the shift. There's a greater shift now. So about 1/4 now of the people surveyed feel that they have no easy access to materials to guide them on antibiotic use. And I think this is all down to awareness of where they can go to get information. So at the end of my talk here, I'm obviously going to talk about the website that you have created, that you have worked very hard on, and a very easily accessible platform by which clinicians and also the public can access, if they wanted, to look and see what the recommended guidelines are for antibiotic usage. That's for me, thanks.
That's great, Prof. Kong. I mean, I think you've done an excellent job, and it's really amazing. I see the surgical team has, done. They are doing very, very well among all the other teams in this hospital, and it's great to know what are the challenges so that we can take the appropriate steps. And and we know now it's the awareness and getting the information, and we can go to the direction. I think we should all do this, do a hospital-wide awareness kind of gauge about, what are the gaps and what are the needs for our healthcare workers. Thank you very much. Thank you so much for that. I also want to say we have 20 participants now, and that's great to know that a lot of people are, on board with this and are interested to know more. So the next question to you, Prof. Kong, is, well, what is the impact of SSI and hospital-acquired infection on our surgical patients? The ones that you see, or are there studies on it? Is it a great impact? I mean, does it have a great impact on their life, on the patient's life, on our lives as clinicians?
Sure. Thanks, Sheila. I'm not sure whether you can hear me because I think the network's ground to a halt here. It's really, really slow. But let me share my screen again. It's really slow. But I think, to address that question, it has a huge impact. There's no doubt about it. So the impact is not purely clearly on the patient side, but it has an impact upon the institution, and also it has an impact upon us healthcare professionals as well. So I hope that you guys can all hear me because my network's really ground to a halt and I really can't see what's going on.
We can hear you clearly, we just can't see you.
Okay, that's fine, as long as you can hear me. So from a patient's perspective, it's not ideal because the thing is, this is a complication and we don't like complications. And as a result of that, the patients actually may have more difficult conditions that we might need to treat them for if they develop hospital-acquired infection. Sorry, I'm really struggling with Zoom here because it's just not cooperating. Clearly, there's going to be an impact upon the patient's physical status. They may have a prolonged length of stay in hospital, and therefore they may become more and more deconditioned. They may develop further morbidity, so more and more infections. And furthermore, they get demotivated, and it hits them psychologically. And that's the last thing we want for a patient to be in hospital for a prolonged period of time and they don't see where they're going. It's very harrowing to see that. Then obviously this has a knock-on impact upon the hospital per se, because the hospital will have to then factor in prolonged stays for these patients. And so therefore we will not have that turnover of patients that we want. And also we now need to think about possibility of developing multi-drug resistant organisms as they have longer lengths of stay, they have more and more exposure to antibiotics to treat a more and more complex problem. So as a result, these two factors then merge. They form almost like a vicious cycle, where then both these factors will make the patient stay for longer. It therefore increases complexity of the demands and requirements that are required to treat this patient. And it also increases the cost. Cost not just financially, but cost to the patient's family, and also to the hospital. And also don't forget about healthcare workers, because we get demoralized because we come into work, we want the best for these patients. We try our very best. And if these patients continue to spiral and they don't improve despite what we do, then it is actually rather demoralizing. And we feel that, we are just not trying to move our patients forward. And I think that can be actually quite a hit psychologically for us too. So I think it has a huge impact, and that's why we should really try to take all the steps required to prevent HCAIs from occurring in the first place.
I agree with you. It is very devastating to us, when we do see a patient and we say that we don't have any antibiotics and we're just going to give you a concoction of whatever we have and see whether you get better. And sometimes because we can't give them antibiotics, the antibiotics, they end up losing a limb or losing their lives, and you're right, that can be very devastating. Dr. Azana, Prof. Azana, Dr. Azana, what about the awareness of antimicrobial resistance among pediatric patients? How are healthcare workers and the parents of these patients, what are their awareness of antimicrobial resistance and their knowledge about how it happens, and could you enlighten us a bit about the pediatric area?
Hi, thanks, Professor Sheila, for the question. First of all, I think before I answer that question, I must say that Prof. Kong's work on the perspectives is amazing, and I really liked it. And I think I have such healthcare, resistance is extremely great. And this is actually especially seen in pediatricians. Deaths can occur even very, very early, and that is extremely devastating, especially if you see deaths occurring as early as day 3, day 4 of life in babies because of health care, or because of antimicrobial resistance amongst these babies and children. So I'm actually unaware of any local research that actually looked at the level of awareness amongst, specifically for parents. But I can anticipate that this will be low. There is a study, however, done by the Oxford University, and this study is called PAUSE. It is a qualitative study, like about 20 who had a recent respiratory tract infection, and actually very few parents actually considered a possible, they themselves as, oh, I'm a low user of antibiotics, you know. But we also learned from that particular study that there is a general misconception that if you use any because if there is antibiotic resistance, patients will die. So they took it as that, as oh, so antibiotics are needed. So, but from this particular study, what I learned as well is that as a public health message to raise awareness amongst parents, we must clearly say misuse. So basically, them aware, it's not to say do not use antibiotics, but it's to say misuse of antibiotics. And this is something that I think will bring on to parents. And the other thing that they are probably not aware of is that children are even more susceptible to resistant bacteria because of their developing immune system. So if they come across a resistant bacteria and they are and you can even get an infection very easily. We ICU all the time. By this, and consequently, it will alter their overall time. Multiple times about how antibiotic resistance alter the gut microbiome or a life that we need for parents. That use of antibiotics is not just in the development of antimicrobial resistance, is that by using too much of antibiotics, you can alter their health outcomes until, for their lifetime. And that awareness of the, even though you can see that in Prof. Kong's study, that quite a number of clinicians know about antimicrobial resistance, they don't exactly know the hows and the whys. And I feel that we should empower the parents, both the parents, the patients, the doctors out there together. And I think this can be done by like an awareness, a very good awareness program like what we're doing right now.
Thanks, Azana.
Yeah.
I think from all these discussions that we had, and it is quite clear that WHO is on the right track, because as you can see, antimicrobial resistance is caused by everybody, right? So so acting against antimicrobial resistance is a shared responsibility. All of us are responsible for reducing the spread and the emergence of antimicrobial resistance. You may be a healthcare worker, a part of the general public, policymakers, farmers, veterinarians, and even pharmaceutical companies, making sure antibiotics are not sold over the counter and reducing the antimicrobial use in food producing animals. I think this is very important for us to know that it's very, very, it's for everybody. So, Human, I've got a question for you. How do you think in the primary care you can reduce antimicrobial resistance, whether it's among yourselves or among healthcare workers or the patients themselves? What do you think can be done?
Yeah, so thank you, Prof. Shashila. I think effective communication is very important, especially in our busy primary care clinic setting. In terms of effective communications, my advice to the junior doctors would be explain to the patients, reassure what is the natural history of an illness and expected recovery, and explain that why antibiotic is not needed and do not self-medicate themselves with antibiotic. So, and when you tell them that I can't give you antibiotic, you must kind of give them a positive treatment recommendation to help them how to feel better, any symptomatic treatment for that. And if you are going to give antibiotic, have to counsel them to kind of complete antibiotic and adhere to the antibiotic. So, and there must be a contingency plan for the patient where you kind of offer them to come back if they are not getting better or the symptoms getting worse. So, and another thing to the doctor is sometimes the clinical uncertainty regarding the diagnosis. It is one of the factors where the doctor tends to prescribe antibiotic and the patient is also unsure the diagnosis. But I would say a watchful waiting strategy can actually reduce the prescription of antibiotic use as well. So my advice to the patients is don't share their antibiotics, and also let the doctor decide whether antibiotic is needed. Yeah, and as you said, that no infection is cured if within 1 day. There's a course of the natural illness of the disease and the expected recovery of the illness. Yeah.
Thank you very much. And also, of course, immunization is very important. And if you're wondering, why is it that if I immunize myself against influenza, I'm going to reduce multi-drug resistant organisms? It's because if you immunize yourself against a viral infection, you reduce the risk of getting that infection. So when you come to the hospital with the infection, we can at least, it reduces your infection rates for coming to the hospital, because as you can see, when you do get an infection and when you come to the hospital, there's a likelihood that you might be given an antibiotic. And also patients feel that they need to be given an antibiotic. So for that viral infection, you start getting an antibiotic, and this is how antimicrobial resistance happens. So if you vaccinate yourself against vaccine preventable diseases, this will reduce you coming to the hospital for these illnesses and hence reduce the risk of getting an antibiotic and emergence. So as you all know, infection prevention and control measures such as using the right PPE, hand hygiene, following the signpost that's on the door of your patient's room on contact precaution, whether it's airborne precaution, keeping the environment clean, education, getting vaccinated, staying at home if you're sick, is very important in preventing COVID. I think we have been hearing about PPEs a lot now since COVID came about, but it was there long before even COVID. It's been used for all communicable disease, whether it's TB or RSV or influenza. It's been used before all your multi-drug resistant organisms. In fact, it has been used for multi-drug resistant organisms for a long time, but sometimes healthcare workers as well as patients forget this and get lax about their hand hygiene. So in fact, it has been shown that with effective infection, WHO has shown that with effective infection prevention and control programs in hospitals, we've managed to reduce healthcare associated infections by 30%. That is your SSI or your line-related infections. However, according to WHO, 90% of healthcare workers do not clean their hands in some facilities. I'm sure in our hospital it's slightly higher, but again, it's not very consistent. Some healthcare workers do it all the time. Some healthcare workers may in labs. So, it is not consistent with microbial resistance. Azana, how do you think pediatrics can how do you think the peds can play a role in infection prevention?
Okay, I think, well, the first step is actually empowering our staff. So I'd just like to show, share my slide here. Let me just share this. Okay. So it's basically empowering every single person as far as possible and empower them, give them the knowledge. Because actually we knew that this is a very big issue in our NICU. We were having recurrent MDROs and especially grown from the tracheal aspirates of our little ones, and we were not spared by the recurrent outbreaks. We had a lot of outbreaks at the time, and it even soared up to 9 cases per every 1,000 patients. And we said that, oh no, this cannot be done just by us alone. So we need to cut across the board. It's got to be the nurses, the every single healthcare worker, including our PPKs, and then also to raise awareness amongst our parents so that they will start to question us. So we realized, we actually put up this poster for hand hygiene, and so that the parents will start to ask us, have you washed your hands, doctor? And then they complain to us, oh, do you know that doctor didn't wash her hands before touching my baby? Those kind of things. And then we had all these little things for CLAPC and all that. And so we said that, oh no, we need to set the stage. We need to create a common goal. So another thing that we also were challenged with is that we knew that for our NICU in particular, we were facing a lot of challenges. Challenges because these babies actually has got very non-specific symptoms and signs. And basically when people say, oh, it's culture negative, it was ill. And conditions like specific conditions where like necrotizing enterocolitis, nosocomial pneumonia, and maternal babies who are born in or where the mothers actually have got maternal chorioamnionitis. These 3 conditions, for example, are notorious for having negative blood cultures. And then the worst part is that when they do die and we do a post-mortem intracardiac culture, it comes back as positive. So, and we know all these maternal antimicrobials to mothers given during labor can mask sepsis, and we do get all these negative cultures, and then later on it becomes positive. So these were the challenges that we faced, and we said that, oh, we need to empower our doctors. So we set forth, we gathered our data, thanks to people like Prof. Rina, who gave us the antibiogram, and also our infection control team together with Prof. Sashila and all. We analyzed the infections. We created our own BSI data, revised our own antibiotic guidelines based on our data. So then we launched our revised guidelines. And as you can see at the back here, so this poster is at the end of NICU. My nurses actually brought this here along, just, our poster. Okay, so we'll show our poster. And so thank you. This one is Zuhaira's very design. And we said, okay, we need to educate and create action. So we said to tell, truly identify, make the diagnosis. Something called the 4 moments of antibiotic decision making. First, make the diagnosis, truly identify the source of infection. Then ensure these blood cultures and taken from the site that is referred. Then you commence the antibiotic therapy, then reassess. What we always say is reassess. Every 48 to 72 hours, reassess. Should you stop? Should you target the therapy? And then you narrow down the spectrum. Okay, and the duration. So all these things should be done during the ward rounds. Really rationalize. It's always the best medicine. This is not enough. That, oh, we need to do this. Definitely. And this was our recent launch of our antibiotic stewardship program just before the MCO. And this is a message that we wanted to share. Okay.
Very much. This looks excellent. I'll answer some questions, and I hope the panel will be able to give me the important messages in these things. So, for example, in the surgical department, Prof. Kong, how do you think we can reduce MDROs, antibiotic use and infection control wise? Is there any methods?
Yeah, thanks, Sheila. So how I see it is basically containment. I've already said that every surgical incision will come with the risk of SSI. So therefore, what we really need is we need to reduce the risk and we need to contain. So I'm not trying to blow our trumpets as surgeons, but I think we are very good at one thing. One of the few things for infection is sepsis control. As we know, antibiotics alone is not going to fight the problem infection. If there is still an ongoing source, if that source is not addressed, the problem will persist. And so we really have a role here in, for example, clearing out perforated appendicitis or clearing out sepsis from perforated bowel, etc. So I have to say that source control is the key for patients who have a surgically related problem. So once we've actually addressed the source surgically, then I think the second strategy to contain the bacteria and trying to prevent infection is literally prevention. So in surgery, there is very good guidance from WHO in order to reduce the incidence of SSI through their bundle. So it's a WHO SSI preventative bundle. And one can look upon this as being not just healthcare workers that are really needing to abide by these rules, but actually the patients as well, because it's actually working in partnership. So the strategy for this actually starts from the very beginning, even from the pre-operative period. For example, we need to control maybe for the glycemic control for patients who have diabetes. We have to give instructions to patients not to shave the skin, particularly with shavers, because we know that that damages skin, and therefore that increases the chance of SSI. And furthermore, they need to know that just simple bathing before surgery doesn't need to be high-end antibiotic impregnated soaps, etc. Just simple bathing actually makes a difference. Then from a healthcare perspective, we'll obviously need to think about keeping normothermia. We need to control for blood sugars intraoperatively, maybe giving some perioperative oxygen and giving them prophylactic antibiotics, which we'll talk about hopefully later in a second. And then post-op is all about the moments of hand hygiene. So if a clinician is going to see a patient with a wound, obviously it makes sense to actually perform hand hygiene adequately, the 7 steps to adequate hand hygiene, so that you actually minimize the transference of bacteria from one particular patient to another patient, and even your own bugs onto that patient. And lastly, the third pillar of strategy for containment, I think, is pretty much isolation. Once you've identified a patient as MDRO, immediate steps need to be taken to isolate that patient in order for that patient not to transmit the bacteria to others. So, and similarly, again, this highlights the very importance of healthcare workers here, because they really need to abide by strict hand hygiene so that they do not act as a vector to transfer the MDRO from one patient to another patient. Thanks.
Surgical antibiotic prophylaxis, what is your thoughts on that?
Okay, so lots of work done already on surgical prophylaxis, and we know for a fact that surgical prophylaxis is indicated in a large overview of systematic reviews, Cochrane systematic reviews. So we are talking about 23 review articles that have been overviewed again. And there's no doubt that the consensus is that surgical prophylaxis plays a role. But the question is, what is appropriate surgical prophylaxis use? So I have to thank Dr. Long from your department, because she provided me with the audit data from last year looking at antibiotic appropriateness. And we are not doing very well from that, unfortunately. So when she looked at the duration, about if I'm not mistaken, only about 60% of the antibiotic use is appropriate. And the other 40% is inappropriate because there has been extended use of antibiotics that is beyond the recommended 24 hours. And when you look at the data for this, across 76 studies done as a Cochrane review of 76 studies, practically all surgical specialties will not benefit from extended prophylaxis. What I mean by that is more than 24 hours use of prophylactic antibiotics. There may be some evidence for its use in cardiothoracic surgery, in vascular surgery, and in dental surgery. But even then, the data and the evidence for that is relatively weak. So at least there is some data to support the use of slightly extended use for those specialties. But for the rest of the other specialties, we know for a fact that if you extend the use of antibiotics beyond 24 hours, not only is there no benefit, but you will cause harm. You actually increase the risk of patients developing MDRO. And thankfully here in Malaysia, we do not see a lot of C. diff. I certainly have seen a lot of patients with C. diff in the UK, and that is a real problem because in a way that is what we have caused. Is a healthcare, is a complication caused by healthcare, and that is not acceptable in my books. Thanks.
Thank you very much, Prof. Kong, and I totally agree with that, and that is something we really need to work on. The duration of antibiotic prophylaxis. I've got a last. People say, so what is antibiotic? Sherry, can you hear me?
Breaking up a bit, but I think the question is new antibiotics, right? Yeah. So
why don't we just give a new antibiotic?
Well, if we had an abundance of new antibiotics, I'm sure we will be the first one to use it. So the development of newer antibiotics is not, new antibiotics are being developed, but the rate of, how quickly we're getting these antibiotics, we're not catching up with the rates of multi-drug resistance that organisms that's emerging day in and day out. And on top of that, these new antibiotics, the development takes a while. And even when they are available, it may not be available in our region or our country. On top of that, a lot of these antibiotics also may have some side effects to it. And let's not talk about the price tag of these antibiotics as well. So if it's there, of course, we will use it, but we don't have enough being developed to catch up with the emergence of multi-drug resistant organisms. So I think it's still very, very important to make sure that we reduce the incidence of multi-drug resistant infection while waiting for the new antibiotics to catch up, if you like.
Thank you very much, Sharifa, and also to all the panel. So I think we don't have much time, but I would just like to end by saying that the take-home message should be that if we do not take any action today, it is estimated by the year 2020, 10 million people will die of multi-drug resistant organisms per year, and this would be more than any other disease, including cancers. And the most affected area would be Asia, as you can see from this projection map. So I think, to go with the team, we need to be united to prevent antimicrobial resistance, all multidisciplinary from different areas, community healthcare providers, and we would need more infection prevention as well as antimicrobial stewardship needs to go together for patient safety and for our general health. So without much ado, I would like to thank the panelists for taking the time and effort to highlight the challenges of antimicrobial resistance in their respective areas and the strategies to combat it, and all the effort that they're putting in their individual department. Thank you very much. I think you will be an example to the whole hospital now on how we move forward. And I also like to thank the Antibiotic Awareness Campaign Committee members for their effort in putting this together, the UMIT and Breakfast of FOM staff for their staff support, and UMNCPR. I hope you will stay on for the AAW and hand hygiene launch and various activities that we did. Thank you very much all, and it was great to see so many people attending this.
Thank you, Sashila, and everyone else.
Yeah, thank you, everyone.
Thank you.
Thanks very much, everyone.
Thank you very much.
Maybe just get to you.
Okay, I'm
Morning, everyone.
Morning, Prof.
Morning, Prof.
Morning. I was on the other
morning.
channel just now, I think.
I think they're switching from the breakfast to the launching now.
Yeah. So I'm on the launch. Like just now I was on the participant side, I think. That was very good. Very, very good. Well done.
Thanks.
You ready?
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh dan salam sejahtera. Yang dihormati Profesor Dr. Nazirah binti Hasnan, Pengarah Pusat Perubatan Universiti Himalaya. Yang berbahagia Profesor Datuk Dr. Adiba Kamruzaman, Dekan Fakulti Perubatan Universiti Himalaya, merangkap penyiasat program World Antibiotic Awareness Week and Hand Hygiene Campaign 2020. Yang dihormati Timbalan-Timbalan Pengarah Pusat Perubatan Universiti Himalaya. Yang berusaha Profesor Madya Dr. Shashila, Ketua Jabatan Kawalan Jangkitan Pusat Perubatan Universiti Himalaya, merangkap pengurusi program World Antibiotic Awareness Week and Hand Hygiene Campaign 2020, Ketua-Ketua Jabatan, Ketua-Ketua Unit, seterusnya tuan-tuan, puan-puan yang menonton secara maya menerusi capaian Facebook Live dan YouTube channel Fakulti Perubatan Universiti Himalaya dan Pusat Perubatan Universiti Himalaya. Majlis mengucapkan ribuan terima kasih terutamanya kepada yang dihormati Profesor Dr. Nazirah dan yang berbahagia Profesor Datuk Dr. Adiba kerana sudi meluangkan masa bersama-sama kita pada pagi ini, juga kepada penonton-penonton di luar sana. Untuk pengetahuan hadirin sekalian, sekarang kita mempunyai lebih kurang 60 peserta sedang menonton secara live melalui Zoom dan mungkin ramai lagi melalui capaian Facebook Live dan YouTube channel. Untuk hadirin sekalian, sungguh pun kita sedang menghadapi cabaran getir bagi membendung penularan wabak COVID-19. Penganjuran World Antibiotic Awareness Week and Hand Hygiene Campaign pada hari ini dilihat dianjurkan pada masa yang tepat. Dengan bertemakan bersatu untuk memelihara antimikrobial dan selamatkan nyawa, cuci tangan anda, atau United to Preserve Antimicrobial and Save Life, Clean Your Hands. Program ini dianjurkan untuk meningkatkan kesedaran umum terhadap pentingnya penggunaan antimikrobial secara berhemah bagi membendung penularan dan peningkatan kuman-kuman kerintangan antibiotik dan kepentingan pencucian tangan yang mampu menghindari kita dan pesakit-pesakit dari kuman-kuman berbahaya, terutamanya dalam tempoh pandemik COVID-19 ini. Hadirin yang dihormati, sebagai pembuka tirai ucapan program World Antibiotic Awareness Week and Hand Hygiene Campaign 2020, pihak majlis dengan sukacitanya mempersilakan Yang Berusaha Profesor Dr. Adi Makarum Zaman, Dekan Fakulti Perubatan Universiti Malaya, merangkap penasihat World Antibiotic Awareness Week and Hand Hygiene Campaign 2020 untuk mencapai ucapan aluan. Dengan ini dipersilakan.
Terima kasih Dr. Sazali. Assalamualaikum semua and good morning all. As Dr. Sazali said, despite the tremendous effort being put into COVID, I'm extremely proud of my colleagues, Prof. Sashila, Prof. Sharifah Farida, Sazali, and the entire infectious disease team who have been working very hard to put on this, not just this morning's presentation, but the whole program for the antibiotic awareness campaign. As you know, and you've heard the statistics, this is a major problem, not just globally, but in our own hospital and in hospitals around Malaysia. And the morbidity and mortality caused by antibiotic resistance is also creeping up. And what is important about it is it's something that can be prevented. I'm extremely pleased to see the involvement of other colleagues, Azana from NICU, Taklun from surgery, and Dr. Lim from primary care. I know years ago when I was almost the lone infectious disease physician at UMMC, and thankfully we now have a big team. It was, and I think it still is, an uphill battle to make people use antibiotics wisely. And sorry, Taklun, are you still there? To get our colleagues to use surgical antibiotic prophylaxis properly, according to guidelines and evidence. So it's extremely pleasing to have a champion because peers only listen to peers, and I hope that the colleagues that we heard from this morning will continue to be champions, because Sashila alone can't do the work, Farida alone can't do the work, and certainly the ID team can't do the work. We're already starting to see some improvement, I guess, in certain multi-drug resistant groups, but it certainly is from the antibiotic stewardship programs that have been put in the last few years, driven by Sashila and the infection control team and the infectious disease team. So we need to strengthen this, and we need to do more of these programs. So the purpose of this global antibiotic awareness week is to get people to internalize and the importance of this issue. Yeah. So the team, it's not just about today. The team over the years has put together programs, not just for colleagues within the hospital, but also to get medical students involved, because as the saying goes, sometimes, not that we've given up on the senior consultants, but as the saying goes, you can't teach old dogs new tricks. Sometimes it's really difficult to get our old colleagues to change their set ways, but certainly training our medical students around the importance of hand hygiene and antibiotics is key. So part of the awareness campaign has been doing quizzes on hand hygiene and antibiotics for medical and pharmacy students, encouraging our cleaners and PPKs. So the infection control unit have been giving prizes for PPK and cleaners from the cleaners ward, because it truly is an all of society response, if you like. And it's got to start with basic things like making sure that we have clean wards and clean beds and clean rooms. So it's a great effort to recognize them and to give them incentives by giving them prizes for lowest MDO rates in the wards and to cleaners and PPKs. Of course, the big effort was in updating our guidelines, which hadn't been updated for a number of years. I think I did it back in 2000, don't know what. And now a big effort from the team. It's one thing to have the guidelines, it's another to make sure that people adhere to it and use it. But I believe it's on the portal, it's on, now that we have laptops all over the world, there's no excuse not to know to which antibiotic to use. You can just quickly refer to the guidelines quite easily. And then, of course, the effort to collaborate with other universities and other KKM hospitals through programs that have been designed. For instance, creating a module that I hope will be on antibiotic awareness and antibiotic stewardship, that I hope we will incorporate into the Clinical Masters training program, as well as be utilized widely through MOOC all over the nation. So that again, this was supported by the MSIDC interest group, but much of the effort also was done by this very, very active and busy team that I'm proud to call my own infectious disease team. So, so I think, hopefully this awareness on the importance of hand hygiene and antibiotic resistance is not going to stop just this week, that it will really be a culture that we practice throughout our practice, because it can't just stop today. There's not going to be, unlike the hope of ending COVID with the recent announcements of effective vaccines, the hope of ending MDROs is not going to come with a super duper vaccine. So it's back to basics, and the basics that you all have practiced for COVID hopefully will continue. Fortunately, you won't have to wear the PPEs. Many of us react to COVID by adhering to the PPE guidelines because we don't want to get it ourselves. With multi-drug resistance organism, it really is about patient care and us caring for our patients. So, the things that we have to do are simple. And if we care for our patients as much as we care for ourselves by adhering to COVID guidelines, we can do the same for MDROs from today and forevermore. Because as I said, there's not going to be a vaccine for MDROs. It truly requires behavioral change and the simple act of caring for our patients. So with that, I want to congratulate once again the amazing infectious disease team, but also the team behind the scenes from the visibility unit who have been working very hard to make sure that we have a smooth presentation this morning and have as many people sign up and benefit from today's presentations. So Sashila and Farida and Sazali and Anjana and everyone else, congratulations once again, and keep up the good work. So thank you. I'm sorry I have to sign off. I have to get on to change my brain cells to talk about prison and COVID now. And after that, prostate prevention. So someone said to me, better make sure, Prof, that you don't talk about decriminalization of prostate because you're jumping from one topic to another. So yeah, so have a good day and good week, and I'll see you all a little bit later. Thanks.
Terima
Bye.
kasih Profesor Dr. Adibah Karamuzaman dengan ucapan seperti tadi. Sesungguhnya usaha untuk membendung peningkatan kuman kerentang antibiotik adalah usaha bersama, bukan sahaja daripada pihak ID, tetapi semua pihak termasuk PPK, cleaners dan umum. Hadirin yang dihormati, majlis seterusnya mempersilakan Yang dihormati Profesor Dr. Nazirah binti Hasnan, Pengarah Pusat Perubatan Universiti Malaya, untuk menyampaikan ucapan dan seterusnya merasmikan program World Antibiotic Awareness Week and Hand Hygiene Campaign 2020. Dengan ini, majlis dengan segala hormatnya mempersilakan.
Terima kasih Dr. Sazli. Bismillahirrahmanirrahim. Yang berbahagia, Profesor Dr. Adibah binti Kamaruzaman, Dekan Fakulti Perubatan Universiti Malaya, merangkap penasihat datang kuasa kempen Minggu Kesedaran Antibiotik. Yang berusaha, Prof. Madya Dr. Sashila, Ketua Jabatan Kawalan Jangkitan, merangkap pengurusi Majlis Sambutan Kempen Hand Hygiene 2020 peringkat PBUM, Ketua-Ketua Jabatan dan Ketua Unit, seterusnya tuan-tuan, puan-puan yang dihormati sekalian. Assalamualaikum warahmatullahi taala dan salam sejahtera. Alhamdulillah, syukur kehadrat Allah Subhanahu Taala kerana dengan izinnya pada hari ini kita dapat bersama-sama untuk menjayakan kempen World Antibiotic Awareness Week peringkat PPUM bagi tahun 2020. Terlebih dahulu, saya ingin mengucapkan ribuan terima kasih kepada hadirin sekalian yang sempat meluangkan masa untuk hadir secara virtual ataupun secara maya dalam majlis perasmian World Antibiotic Awareness Week dan Hand Hygiene Campaign 2020. Saya harap ramai juga yang telah mengikuti forum yang telah diadakan daripada pukul 8 hingga 9 sebentar tadi. Congratulations Prof. Sheila and Prof. Sharifah and team. I attended the forum, really enjoyed it very much and well done to all involved. Sudah pasti sambutan pada tahun ini sedikit berbeza, saya rasa banyak berbeza sebenarnya daripada tahun-tahun sebelumnya berkaitan pandemik COVID-19 yang melanda. Namun sekarang adalah masa paling tepat untuk kita melancarkan kempen ini bagi menekankan kepentingan mencuci tangan dan meningkatkan kesedaran terhadap masalah kerentangan antibiotik ataupun antibiotic resistance. Tema bagi sektor kesihatan manusia untuk World Antibiotic Awareness Week 2020 adalah United to Preserve Antimicrobials. Manakala tema untuk kempen kebersihan tangan pula adalah Save Lives, Clean Your Hands. Kebersihan tangan bukan sahaja terbukti penting dalam memerangi COVID-19, tetapi juga merupakan langkah yang paling penting untuk menghentikan penyebaran kuman kebal antibiotik dan mengelakkan jangkitan kuman di hospital. Untuk memperkukuhkan pematuhan kebersihan tangan di kalangan pekerja penjagaan kesihatan, PPUM telah memasukkan kadar pematuhan kebersihan tangan iaitu kadar hand hygiene compliance sebagai salah satu petunjuk prestasi utama hospital. Tahap KPI bagi kadar pematuhan kebersihan tangan telah ditingkatkan kepada 80% pada tahun 2019. Saya dengan sukacita ingin menyatakan bahawa dengan usaha ini, PPUM telah mencapai KPI yang disasarkan. Walau bagaimanapun, kita tidak boleh bangga dan gembira dengan tahap pencapaian ini. Kita perlu lagi meningkatkan tahap pencapaian hand hygiene compliance rate kita dan kita memerlukan semua di dalam hospital ini untuk sama-sama menjayakan kempen dan menghadapi cabaran ini. Tuan-tuan dan puan-puan, bagi menghadapi cabaran kerentangan antibiotik, PPUM telah menubuhkan jawatankuasa kawalan jangkitan hospital dan antibiotik. Bagi tujuan mengurangkan penggunaan antibiotik broad spectrum, kita telah melaksanakan pengisian borang kelulusan antibiotik carbapenem dan meneruskan usaha antimicrobial stewardship rounds bersama beberapa ward perubatan dan surgery di hospital ini. Saya mengucapkan tahniah, syabas dan terima kasih kepada mereka yang telah bersama-sama memberi kerjasama dan menjayakan program ini. Selain daripada itu, kita juga telah melancarkan perkhidmatan terapi antibiotik pesakit luar ataupun OPAT bagi memudahkan pemberian antibiotik intravena secara pesakit luar dan secara langsung mengurangkan keperluan menjadi pesakit dalam secara berpanjangan serta membantu mengurangkan risiko jangkitan daripada hospital. Pada tahun 2019, kita telah melaksanakan National Antimicrobial Prescribing Survey ataupun NAPS dan didapati bahawa kesesuaian penggunaan antibiotik secara keseluruhan adalah sebanyak 64%. Berdasarkan data pengawasan antibiotik oleh Kementerian Kesihatan Malaysia pula, PPUM merupakan salah satu hospital yang berada pada 5 tangga teratas untuk penggunaan antibiotik carbapenem, piperacillin, tazobactam dan ceftriaxone, dan kedapatan ini adalah amat membimbangkan. Tuan-tuan dan puan-puan yang saya hormati, di PPUM, keselamatan pesakit adalah keutamaan kita. Dan sebagai sebuah hospital pengajar, kita perlu melakukan tindakan yang sewajarnya untuk meningkatkan kesedaran mengenai kepentingan menangani masalah kerintangan antibiotik dan mengelakkan jangkitan kuman di hospital. Oleh itu, besarlah harapan saya agar semua orang dapat terus bertahan dalam memperjuangkan kebersihan tangan dan kawalan jangkitan. Kita tidak boleh putus asa walaupun ada cabaran yang tinggi, tidak boleh putus asa. Saya selalu bagi tahu Puan Sheila, we cannot give up. Kita sentiasa kena memperjuangkan kebersihan tangan dan kawalan jangkitan di PPUM bagi memastikan jaminan kualiti terbaik kepada pesakit di PPUM. Dan sebagaimana yang telah didengari semasa forum tadi, prevention of antimicrobial resistance is a shared responsibility. Itu adalah kata-kata hikmah daripada Prof. Sheila dan kita kena ingat itu. It's everyone's responsibility, daripada konsultan kepada Dr. Siswaza, kepada nurse, kepada PPK, semua yang terlibat di dalam perawatan. Dan sebagaimana yang kita dengar daripada Prof. Sharifah, Prof. Azana tadi, bukan sahaja healthcare workers yang memainkan peranan di sini, tetapi pesakit juga sangat memainkan peranan, dan public juga perlu memainkan peranan yang penting. Di kesempatan ini, saya ingin mengucapkan tahniah dan syabas kepada Jawatankuasa Antibiotic Awareness Week dan Hand Hygiene Campaign PPUM serta Jabatan Kawalan Jangkitan di atas usaha menganjurkan World Antibiotic Awareness Week dan Hand Hygiene Campaign 2020 di peringkat Pusat Perubatan Universiti Malaya. Akhir kata, dengan lafaz Bismillahirrahmanirrahim, saya merasmikan World Antibiotic Awareness Week and Hand Hygiene Campaign 2020 peringkat PPUM dengan tema United to Preserve Antimicrobials. Save lives, clean your hands. Sekian, terima kasih.
Access denied. Access denied.
Access granted.
Majlis mengucapkan dan perhargaan tidak terhingga kepada Yang Berbahagia Profesor Dr. Nazirah kerana sudi merasmikan majlis kita pada pagi ini. Tahniah juga kepada ahli jawatankuasa terutama Dr. Kerana dengan video yang sangat menarik tadi. Hadirin sekalian, untuk makluman semua, bersempena dengan program World Antibiotic Awareness Week and Hand Hygiene Campaign 2020, pelbagai pertandingan dan kuis telah dianjurkan bagi meningkatkan kesedaran kepada warga hospital dan pelajar-pelajar perubatan serta farmasi di hospital. Kini adalah masa yang ditunggu-tunggu bagi semua pihak. Tibalah masa untuk pengumuman para pemenang. Marilah kita sama-sama saksikan montaj untuk pemenang-pemenang. Tahniah kepada para pemenang, kepada yang tidak berjaya, kita usaha pada tahun hadapan. Sebenarnya bukan sesuatu yang mustahil untuk mencapai tahap yang sehingga 100% seperti yang ditunjukkan oleh para pemenang. Semoga kejayaan mereka menjadi semangat untuk kita pada masa akan datang. Tahniah sekali lagi kami ucapkan kepada para pemenang dan diminta para pemenang untuk hadir ke Jabatan Kawalan Penyakit untuk menerima hadiah. Hadirin sekalian, hijau pamah bermandi rintik, damai terpahat, indah tersemat. Harus berhemah guna antibiotik, hidup sihat dijamin selamat. Kayuh perahu kiambang menyisih, bawa muatan bunga selasih. Cuci tangan sampai bersih. Cukup sekian, terima kasih. Dengan ini, maka sempurnalah sudah Majlis Perasmian World Antibiotic Awareness Week and Hand Hygiene Campaign 2020. Majlis sekali lagi ingin mengucapkan terima kasih kepada Yang Dihormati Profesor Dr. Nazirah dan para tetamu-tamu terhormat dan penonton-penonton di luar sana kerana sudi memeriahkan lagi majlis kita pada hari ini. Sebelum majlis kita bersurai, saya bagi pihak jawatankuasa program ingin merakamkan jutaan terima kasih atas segala kerjasama yang diberikan. Segala kelemahan yang berlaku sepanjang majlis ini berlangsung, kami memohon ampun dan maaf. Sekian, terima kasih. Jumpa lagi.